Welcome to the lecture for Abnormal Psychology. We'll be talking today about somatoform and dissociative disorders. So, a little overview we'll talk about in terms of somatoform disorders, somatic symptom disorder, illness anxiety disorder, conversion disorder, and then a little bit about fictitious disorder and malingering. The dissociative disorders include depersonalization-derealization disorder, dissociative amnesia, and DID, dissociative identity disorder. Okay, starting off with the somatoform disorders. Generally, these disorders are characterized by a pathological concern with health or bodily sensations, right? So either thinking you're sick or you've got some symptom that might mean you're sick, and there's a pathological level of concern. So can you actually have a medical condition and still have a somatoform disorder? Sure. So let's say you have basal cell carcinoma. Pretty treatable skin cancer. You have then you go, I have this basal cell and they're going to be everywhere and they're going to metastasize and I'll be dead in 2 weeks, and you have lots of anxiety about that, and your doctor tells you, no, actually this is really treatable. We're just going to cut it out and it'll be gone. No radiation. It doesn't typically spread. We caught it early. You're fine. But that reassurance doesn't help, and you're still concerned. So yeah, you have there is a general medical condition. You're not just making it up. But the level of concern you have is disproportionate to kind of the threat that you're facing. However, it is important to keep in mind that a small percentage of people that get diagnosed with one of these disorders might still get diagnosed with disorder because the doctors think, well, they don't really have anything. Nothing's really wrong with them. And there is a bit of a change here in DSM-5 from DSM-4. In DSM-4 for TR, there was a requirement where clinicians really had to figure out, for the most part, that these symptoms are present and they're not due to a general medical condition. DSM-5 changes it. No, it's fine. If there's a condition there, sure, but you're just overly concerned about it. But still, if the doctors don't think there's any disorder there and you're having lots of symptoms, you might get diagnosed with a somatoform disorder. But you might really have a disorder and they just missed it, Medicine is as much art as it is science, right? We like to believe that it's all figured out and they know these diseases, they know how they work. You present to the symptoms and the doctor tells you what you have, you take the medicine and you're fine. And for the most part, it works out that way. But not all the time, especially with some autoimmune things. There's still things we don't understand. And so people can present with these kind of bizarre symptom patterns where sometimes physicians will think, oh, it's psychosomatic. There's no organic cause. It's because of how they're thinking about things. When no, you don't understand the pathology. There is some sort of pathogen or some sort of systemic problem that just hasn't been identified. So that's important to keep in mind if you're ever working with these individuals. A term we'll talk about a lot is somatization. And somatization is something that obviously is associated with these disorders, but it's also something that occurs outside of these disorders. And somatization is just the tendency to experience psychological stress, psychological symptoms as physical symptoms. And there are a lot of there's some cultural differences in the degree to which people tend to somaticize. There's some age differences. Kids tend to be more of somaticizers than adults, right? So that kid that says, oh, I don't want to go to school, my tummy hurts, and they're not lying, their tummy really does hurt, but their tummy hurts because they've got a big project due that day, or somebody's bullying them at school. So that anxiety, that stress is coming out in a physical manifestation. And part of it is, especially with kids, is they don't have the emotional vocabulary to say, oh, I'm really stressed and worried and it's bothering me. Because when we're stressed and worried, our stomachs kind of hurt. And they think, oh, my stomach hurts, I must be sick. They don't necessarily make the connection between those physical symptoms and the psychosocial stressor that they're facing. Okay, on to the disorders. Somatic symptom disorder. So this replaces in the DSM-4 really two disorders: somatization disorder and undifferentiated somatoform disorder. Which somatization disorder, you had to have two of this type of symptom, like 2 GI symptoms, a neurological symptom, a pain symptom. You had to have all these specific symptoms in different categories, and it was very precise. And so few people met criteria for it because people present all kinds of different symptom patterns. Undifferentiated somatoform disorder is more of kind of what somatic symptom disorder is. Well, some symptoms, But again, one of the big changes here is that they don't say you have to rule out, oh, that these symptoms aren't due to a general medical condition. Even if you have a general medical condition there, you could still be diagnosed with somatic symptom disorder. So you've got one or more somatic symptoms that are distressing or disrupt daily life, right? And somatic just being bodily symptoms. So, you know, headache, stomach ache, pain, you know, excessive diarrhea, whatever, some sort of bodily symptom, one or more. And so the part that gets pathological is there's excessive concern with your health manifested by at least one of the following. So disproportionate and persistent thoughts about the seriousness of the symptoms. So this is again where you kind of go back to that basal cell carcinoma where, okay, basal cell, yeah, it's treatable. We cut it out, you know, we freeze it. You can put a topical solution on it. There's lots of ways to treat it. It's not really lethal. You're going to be fine. But if you keep thinking about it almost obsessively, a little bit like obsessive compulsive disorder, but it's different, right? People that have intrusive thoughts that they're ill, if those are experienced as intrusive and they have a hard time controlling them, well, then OCD is a better diagnostic category for them than the somatic symptom disorder. But it does kind of have that feel to it, but it was a little bit less of the obsessive tendency, I would say. But there's a disproportionate persistent thoughts. So having lots of thoughts about how serious it is. Oh, this could be really bad. I think I may be dying. I may not recover. You know, telling your friends goodbye. Or persistently high level of anxiety about the symptoms. Right. So oftentimes you have symptoms, and then you go to the doctor and they tell you, okay, here's what it is. Here's the plan. You go, okay, yeah, this is going to suck, but I'll get through it. Somebody with somatic symptom disorder, even though they have a plan of action, here's a treatment, yeah, but I don't know, it's not going to work, and oh, this is really bad, and what about this, what about this? And so that anxiety just stays high despite getting reassurance, or you know, they don't go to the doctor because the anxiety is so high. Well, they're just going to tell me I have cancer. Why would I go? But then they stay anxious about it. And then, or the third one, excessive time and energy devoted to the symptoms. So always spending, used to be, you know, reading books about it. Now it's going on WebMD and Wikipedia, looking up all these symptoms. What could it be? Could it be this? Could it be this? Oh, what do I do? Oh, I think I may have had a great uncle who had this. I definitely have it. So they're becoming these kind of medical researchers, devoting all kinds of time and energy to these symptoms. That again, and it's not like they're in an episode of House where nobody knows what's going on. They typically have been to a physician or multiple physicians and have been reassured, okay, yeah, here's what these symptoms mean. Either, yeah, they mean you have this disordered disease problem and we're going to treat it, or that's just you were hungry. Could be, you know, and you're misinterpreting these hunger pains as stomach cancer. But they've either been reassured that there is something and it's treatable, or that there's not something. Nevertheless, they're still investigating, spending all this time thinking about it, looking into it. So the symptoms, so headache, stomach ache, those can kind of come and go, and different symptoms can come in and out of the picture. But the overall state of being symptomatic, of having some symptom, some somatic symptom, is present for a while. It's persistent, generally at least 6 months, right? So if you first get diagnosed with something, yeah, for a week, 2 weeks, a month, maybe you're kind of worried about it. Maybe even 3 months. If it goes beyond that, starts getting closer to 6 months, then we think, okay, well, this might be more pathological rather than a normal reaction to the stressful event. And if you think back about stuff we talked about before, a diagnosis of a disease in someone that causes anxiety, depression, maybe some disruptive behaviors for an extended period of time might be criteria for something else. Like an adjustment disorder with anxiety or depressed mood or mixed or with disruptive behavior. So again, but those tend to be more time limited, less than 6 months. Longer than that, okay, now we're looking maybe at something else. Maybe it is this somatic symptom disorder. And in terms of specifiers, you specify if there's predominant pain. So if pain is a big component of the symptom picture, that's important. Those individuals tend to have unique issues in terms of medication seeking and pain management, psychologically, biologically, incredibly tricky. Specify if it's persistent or not, and then the severity of the concerns. And that severity part is really come about the second group of symptoms, the disproportionate thoughts, persistently high anxiety, excessive time and energy. If you have all three of those, okay, that's going to be high. If you have two, moderate, one, it'll be low. So the number of those symptoms, and also in considering the severity, you're also going to look at the number of somatic complaints they have. If it's just a headache, just GI, okay, maybe that's mild. If they have multiple somatic symptoms, then it's going to tilt toward the higher end of severity. Okay, in terms of prevalence, it's not really known. Maybe 5 to 7%. And again, this is something that somebody with a somatic symptom disorder isn't going to present to a psychologist or a counselor saying, hey, I think I'm really physically ill, but I'm probably not. Can we talk about it? Where are they going to go? They're going to go to the doctor. So we have some data from presenting to doctors how many people ultimately are ruled to not have a general medical condition or to have anxiety in excess of what's appropriate. And based on those numbers, guesstimating the general population, 5 to 7%. So not as rare as some of the other things, but also not super common. And again, somaticizing, experiencing anxiety, stress, depression as physical symptoms, super common, right? If you look at like the diagnostic criteria for major depressive disorder, there are somatic symptoms in there, right? That loss of appetite, increased appetite, those are somatic symptoms. So you're experiencing this psychological problem physically. So somatization in general, really common, but the disorder itself, not that common. In terms of causes, again, probably a biological, psychological vulnerability for stress, like we've talked about before with anxiety disorders. Same type of thing happening, right? Where people are going to be lacking some coping mechanisms and having a tendency to look at the world in a way that leads to the experience of stress, right? And then how you deal with stress in a pathological way depends on some other stuff. One thing it might depend on how it might manifest as somatic symptom disorder is if you have a family history of illness, right? And there's a variety of reasons for that. One of which being if there's a family history of illness and you saw an ill family member get attention from others, you saw them maybe get out of having to do certain unpleasant tasks. Okay, there might be some kind of back of your mind motivation there, right, to take on that role. But again, that's not something people are doing consciously in a somatic symptom sort of kind of presentation. Another interesting thing is that there's this possible link with antisocial personality disorder. And I know we haven't talked about the personality disorders yet, but antisocial personality disorder, briefly, isn't about being antisocial in terms of, I'm not going to that party, people are stupid. It's more in terms of most everybody in prison meets criteria for antisocial personality disorder, right? It's the inability, the refusal to comply with societal norms, standards, and rules, right? So people that take advantage of others, that lie, cheat, steal, rob, that just don't think the rules apply to them. That's an antisocial personality disorder. So there's this interesting link with somatic symptom disorder in that women who are diagnosed with this disorder, or really who in the past were diagnosed with somatization disorder or undifferentiated somatoform disorder, because we haven't had this diagnosis long enough to have a lot of research on it, but on the kind of DSM-IV equivalents, women diagnosed with those disorders were significantly more likely than women not diagnosed with it to have a first-degree relative who is diagnosed with antisocial personality disorder, suggesting possibly some shared genetic vulnerability for those two disorders. And antisocial personality disorder, much more common in men. So what if whatever that genetic vulnerability is gets manifested, gets realized in different ways based on gender roles? Okay, if you have these genes that lead to these pathways or these structures in the brain, somehow, if you're in the female gender role, it leads to this somatic symptom disorder, and if you're in the male, it leads to this antisocial personality disorder, which is weird because they don't seem similar at all. I don't know if you guys can figure out the connection. Doesn't make sense to me. In terms of treatment, nothing works great. Kind of limited efficacy in treating this. Ironically, often the recommendation is give them reassurance that they're okay. You know, one of the characteristic things is they typically aren't helped by reassurance. But what do? Well, one thing that people do in practice and kind of medical practice, and this isn't so much about helping the patient as it is about helping the system, because in terms of resources, individuals with somatic symptom disorder are a significant drain on healthcare resources, right? So they don't really have an illness, or they don't have the level of illness that they think they have, but they're presenting to physicians and taking up more time, having more tests run, and there's a limited amount of medical resources to go around, obviously, and they're taking those up when they may not need as many resources as they are asking for. So what often happens is when these people are identified, they're assigned a gatekeeper physician. So instead of being able to go to the nephrologist and go over to the orthopedist and go to the dermatologist and go to the ophthalmologist for all these different symptoms they keep having, they're assigned in a kind of integrated healthcare system, they're assigned a primary care physician that they have to go to first, right? So even if your insurance doesn't say you need a referral, you've got to get a referral. You've got to see this person, and they'll determine if you're going to see a specialist or not. It keeps them from keep going to one specialist to the next once they get turned down for treatment or told that their symptoms aren't as bad as they think they are. And again, that's just mostly trying to control cost and limit the number of resources these individuals are taking up, which is good, I guess, for the system. But again, if this person is somebody who has one of those mystery illnesses, that may not be the best. I don't know. Overall, though, in terms of psychosocial treatments, overall, you're just looking to reduce their overall stress levels, right? So stress management techniques, the same kind of things you would use with somebody with generalized anxiety disorder, right? If you think that these somatic symptoms are because of stress, okay, well, let's not deal with this problem of, well, why do you somaticize? Well, this is just a manifestation of your stress. Let's just deal with your stress. Because if we deal with your stress, then you'll no longer have this blurred vision and dizziness and all these other somatic symptoms, right? Okay, illness anxiety disorder. DSM-V really loves renaming things. I don't know why. For a long time, this was known as hypochondriasis, right? So we have the term hypochondriac, hypochondriacal. New name. Not much difference in the diagnosis, though. Still a preoccupation with having or acquiring a serious illness. So either you think you have an illness or you think you're gonna get one. And again, there's some overlap here with OCD, right? If you have OCD where you have obsessions about germs, or you're a germaphobe, I don't want to touch that because I might get sick. Well, if I might touch that and get sick, that's OCD. I think, oh, I touch lots of things. I'm probably sick now. I think I can feel the bacteria in my body right now. That's more of a hypochondriasis illness anxiety disorder because you didn't keep yourself from touching the things, right? Someone with OCD has the thoughts and avoids, right? They have a compulsion to deal with that anxiety. This is more no, I have it. I'm gonna have it. I'm gonna get it. I've had the exposure. Now I'm gonna get it. I went to that little kid's birthday party. The little girl sneezed. Now I'm gonna get the flu. And if I get the flu, I'm gonna get immunocompromised. And then I'm gonna get hepatitis, right? And they go on and on and on. Kind of spiral out sometimes. So either I'm gonna get sick or I am already sick. So this is different from what we just talked about, right? From the somatic symptom disorder. So in that one, there's this concern with symptoms. My heart is just racing really fast. I don't know what it is, right? So those individuals aren't necessarily saying, my heart's racing real fast. I think I have aortic stenosis, right? They're not diagnosing themselves typically. They're saying, I have this symptom. I don't know what it is, but the symptom is bad. And this obsession with symptoms. Illness anxiety disorder is a little different. It's not really about the symptoms. It's about the illness, and the symptoms can come and go. I think I have the flu because of this. Oh, that's not a symptom of flu. Okay, no problem. And they let go of that symptom easy because they're not tied to the symptoms. They're more tied to the illness. Well, what about this? Maybe this is the proof that I have the flu, right? So in general, significant somatic symptoms aren't present. If they are present, they're mild. So they don't have the same type of signs of illness that someone with somatic symptom disorder does. They're fairly asymptomatic. They just have, it's more about misinterpreting regular bodily functions here, whereas the other one is more about thinking you have symptoms. They have a high level of anxiety about their health, obviously. And then there's excessive health-related behaviors, or they exhibit maladaptive avoidance. So what's an excessive health-related behavior? Well, that's going on WebMD every day for an hour a day, typing in symptoms. Do I have this? Do I have this? Do I have this? Right? Or checking in the mirror, that spot on your face. Oh, I think that's malignant. I think that's malignant. That's probably bad. I should probably look at that. Going to doctors repeatedly over and over again. One doctor says, no, you're fine. Find another one. Find another one. Doctor shopping till you find one that says you have something. That would be an excessive health-related behavior. Interestingly, you might also have the opposite, where you are so sure that you are sick that you avoid doing anything about it. Well, I have my annual physical scheduled, but I know I have lupus, so why would I go? I read about it. I know I have lupus. I'm not going to pay somebody to tell me. No, because there's that anxiety about getting it confirmed. Anxiety that you have it, but then also don't want that interaction. Which is weird that the same diagnostic category, you can have people that really have opposite ways of approaching this concern about health. Which again goes back to what we talked about before. These diagnostic categories can often be very heterogeneous, right? You have some very different people all with the same label. So when you know the label, you know a little bit about the person, but it's important to keep in mind, you don't know that much. There's still lots of questions to ask to figure out what's going on with them. You've just narrowed the field to say, okay, illness, anxiety disorder. Okay, so it's not psychosis. It's not depression. It's this other thing. But once we know this thing, well, which type of this thing is it? So this illness preoccupation, the concern about being ill or getting ill, again, is kind of persistent for at least 6 months. So again, maybe for somebody you know gets sick, and then for a little while you think, oh, I think I'm going to get it too. That's pretty common, happens. But if it persists, for half a year, now, okay, maybe it is this illness anxiety disorder. And of course, it's not better explained by the effects of a general medical condition or drugs or another disorder. And then you specify if they're the care-seeking type or the care-avoidant type. So that goes back up to that one about excessive health-related behaviors, seeking doctors, or the maladaptive avoidance. So you specify which one, because the idea being that the course of the disorder and possibly the treatment of the disorder will be different depending on which typology we're looking at. Okay, in terms of prevalence, well, that's weird. Estimates based on the previous disorder, hypochondriasis, the 12-month prevalence rate between 3 and 8%. So again, similar in range to somatic symptom disorder. For causes, again, probably some sort of non-specific genetic influence, similar to what we see in anxiety disorders. It tends to run in families. But what tends to run in families is more of a tendency to over-respond to stress, to respond in maladaptive ways to stressful situations. Some learning is probably involved. Among individuals diagnosed with this disorder, they commonly report a history of serious illness in childhood and or past experience with illnesses in family members, right? So, and again, think of that, those formative years, if you have an illness and you're in bed for a long time, yeah, that might make you worried about getting sick again, because when you're a kid, you want to go play and have fun, and your friends are outside, or they're playing video games, and you're stuck in bed and can't talk to anybody. That sucks, and you can imagine that might make you really hyper vigilant about getting sick again, right? To where, okay, well, I'm feeling a little itchy. I wonder what this might be a thing. Oh, this might be. That was so bad. I don't want to do it again. Something you see somebody else really suffering a lot, especially early in your life. It kind of puts that fear in your mind of, oh, I don't want to see that. I don't want to experience that, because I can see how bad it is. So if you have this kind of vulnerability to not dealing well with stress and these kind of learning events, that might lead to the development. And then we also see there's a pretty high frequency of kind of prior to onset of disorder of some sort of loss, a stressful life event, and in particular a loss or a death. And it doesn't even have to be death from an illness that they then think they're going to get. Somebody died of heart disease, now they think they have heart disease. Just any kind of death that's kind of shaking their belief. And again, when you're young, especially, let's look at adolescence, when you think you're bulletproof and going to live forever. if you experience a loss of someone close to you, that kind of shatters that worldview, shatters that belief. And again, if you have this vulnerability to stress, you may be then put on the path to, oh wow, I'm not immortal. I'm going to die someday. In fact, I probably will die. I'm probably going to be sick right now. Excuse me. In terms of treatments, cognitive behavioral therapies. Also, anti-anxiety drugs are often prescribed because it is kind of an anxiety disorder, obviously illness, anxiety disorder. And like most anxiety disorders, the drugs are good at making you not feel anxious when you take the drugs. But you can't take the drugs forever because they tend to be habit forming. And you have some rebound anxiety sometimes when you try to cut back or stop taking them. So for some people, it may be good to, if they have really high anxiety, to bring it down enough that they can start some other treatment, but it's not a long-term solution generally. Okay, conversion disorder, one of the ones that's got the most lore in the world of psychology. Right? This is what Freud and Breuer were working with back in Vienna with all those rich Viennese people that had these symptoms, these weird neurological symptoms that didn't make sense. And the idea being that, okay, you had some sort of traumatic event and you converted the stress of that into a neurological symptom. So one or more symptoms of altered voluntary motor or sensory function. That's fancy. Or one or more neurological symptom, right? So motor functioning, so some paralysis or difficulty moving, ataxia, loss in sensation, numbness, or sensory functioning, blurred vision, blindness, deafness, lack of taste or smell, right? So some sort of neurological symptom, at least one or more. But there's an incompatibility between the symptom presentation and recognized neurological and medical conditions. And this is often how these things are diagnosed, where, okay, I've got this paralysis where I can't move my thumb. I can move my other fingers, but not my thumb. My thumb is totally paralyzed. You know, a neurologist said, well, that's not how nerves work. Like, that doesn't make sense. Like, we've done imaging, and the way the innervation works, if the thumb can't move, then this other part of your arm shouldn't move as well, because they're controlled by the same neural pathway, right? So they know enough about neural pathways that if anybody who isn't a neurologist has some kind of weird symptoms, they can often go, yeah, that's not how it works. It doesn't make sense. You can't have glove anesthesia where you just feel nothing in your hand, but you can feel everything in your arm, and you can feel everything in the other hand and your feet. It's not how it works. So there's some incompatibility between how we know the brain and spinal cord and nerves work and how people are presenting. The symptom deficit is not better explained by another medical condition or disorder. Yada yada. Causes clinically significant distress or impairment. And then you specify the type of symptoms. You specify if okay, so transient symptoms are common, and that's fascinating. So it's relatively common for people to have these kind of weird neurological things that aren't really the result of brain damage or dysfunction. Or, oh, I went blind for a little bit. Really? Yeah, that's fine, normal. If it goes away, so something traumatic happened, and then you're briefly paralyzed, or you shuffle for a while, and then it goes away. Yep, not conversion disorder, just a transient symptom, comes and goes. In terms of meeting full criteria for the disorder, again, like a lot of these somatic disorders, we don't have good data on it because they don't present to psychologists and counselors for this. And estimates for in the medical field, where they're going to present to neurology and neuropsych, big range. It's between 5 and 30%. That's a big difference. I wonder why. And again, part of it is because it's tricky, and neurologists are hesitant to diagnose conversion disorder because they don't want to be wrong. They don't want to say, oh, this is conversion disorder. This isn't the way the brain works. This is all in your head, as it were. But really, no, here's the tumor. We found it a week later. Wow, crap. That was a weird place for a tumor to be, right? So maybe underdiagnosed in some settings. In terms of the causes, it kind of goes back to Freud in some respects. The way we think about this in terms of there being primary and secondary gain. Primary gain is what the person gets in terms of relief from stress and anxiety, right? So thinking being that something happened, often something traumatic, that causes anxiety, and having this symptom gives you relief from that. And that would be your primary gain, right? Because now your focus is shifted away from the stress or the memory of that trauma onto this physical symptom. So instead of thinking about how this horrible thing happened to me, I think, oh yeah, look, my hand is numb. That's weird. It's kind of my hand. I can't feel anything, right? I'm going to spend lots of time thinking about, talking to people about how my hand is numb, and I no longer have to think about that horrible thing that happened to me right before my hand got numb. And then secondary gain can happen also. It's not like one or the other. They often can coexist. That's whenever, as a result of having the symptom, either you get out of kind of negative things, work, boring tasks, or you get things. People kind of are nicer to you and they help you with things. That would be secondary gain. So primary, the relief from the anxiety. Secondary is getting out of crappy stuff or getting good stuff. And as I already said, the thinking here is that there's usually some traumatic event where these symptoms provided escape at the time or afterward. And so often the symptom presentation aligns with the trauma in kind of interesting ways, where somebody that sees something traumatic then presents with, yeah, I can't see anything. I went blind, right? They went blind because they don't want to see what they saw. Or people that are sexually assaulted, experiencing types of paralysis, because again, during the assault, being fearful for your life and just kind of going limp and not moving. And so then that becomes a symptom that, okay, now I'm limp and I can't move and I have no control over my body afterward, because again, that was something that provided escape at the time, because it's nothing I can do, I'm not here. And then it kind of stays with you. And then kind of like the other somatic disorders, there's often a family history of illness with conversion disorder. So some learning has gone on at some level about what happens when you're in that sick role. Right? In terms of what do you do for these folks, treatment? Well, again, it's almost always about trauma, right? Some traumatic event happened, and your way of dealing with it was to develop these neurological symptoms. So you process the trauma, kind of like you do with PTSD. And that's all about telling the story of the traumatic event until it doesn't bother you, and learning skills to deal with that. Also learning skills to reduce stress, because the conversion symptoms often get worse in times of heightened stress. Somebody may be doing well, oh yeah, my leg's not so stiff today, I can walk again, and then kind of shitty day at work, oh, it's acting up again, now I can't, it's locking up, yeah, I can feel it, it's, yep, oh yeah, can't bend at the knee anymore. So they tend to be responsive to stress, so reducing stress can help. And the other thing is reducing secondary gain. So if we're working from more of a systemic perspective, kind of like a marriage and family therapist, you'll want to meet with family members, loved ones, possibly even teachers, or if it's a child, or co-workers, to talk to them about, okay, when they do this, don't help them. It seems cruel, but they're not really paralyzed, and they're getting something out of this. And so talking to people about finding ways to do that, to not feed into the secondary gain without really damaging the relationships. It's pretty tricky. Okay, some related diagnoses or diagnostic decisions. Factitious disorder. This is a weird one. So falsification or induction of symptoms of illness or injury. So this is sort of like when I was a kid and didn't want to go to school, and I would take the thermometer, hold it next to the light bulb, right? And then mom comes in, yeah, look at your fever. Wow, 150. You are really sick. Yeah, I can't go to school. So faking symptoms, and it could be like faking test results like that, or it could be a bit more, where, drinking some bleach, or, they sell things, at the drugstore to make you throw up, in case of poisoning, taking those things to induce vomiting or diarrhea. So faking symptoms or inducing, making yourself sick. But this isn't to get out of going to school. The kind of person who does this presents themselves as ill, impaired, and injured. And that's really important to them in terms of an identity. They are a sick person. We'll talk about it being assuming the sick role. And the thing that makes it different than the getting out of school is the symptoms persist in the absence of secondary gain. Right? So faking sick, okay, yeah, now you lost your job or you got kicked out of school. So there's no longer, you're not getting anything out of it. Right? You're not getting out of work. Nobody's helping you, but you're still sick. Okay, well, you're not faking it to get something or get out of something. You're faking it because you really want to be seen as this sick person, right? And it seems to be this relational thing that they enjoy, doctors coming and checking on them. Weirdly, and this is more anecdotal in the literature, they really like doctors coming and checking them, not so much nurses. They tend to be pretty rude to nurses. And that could be because nurses are often interact with patients much more than doctors, at least in a hospital setting. And so they are probably more likely to catch on to the fact that the person isn't really sick, and then we'll treat them not like a sick person. And they don't want that. They want to be treated like an ill or injured person. Okay. Factitious disorder imposed on another. And again, DSM-V loves changing things. This used to be factitious disorder by proxy. And before that, it was Munchausen's by proxy, right? The famous story of Baron von Munchausen. And this is a sad one. This is it's child abuse, typically what it is. This is when you're faking someone else's symptoms. So faking or inducing symptoms in someone else. And almost exclusively, it's a parent doing this to a child, making a child sick. And the child often doesn't know that it's happening. The child isn't typically complicit in it, where they're saying, okay, yeah, I'll take this, it's going to throw up. Okay, cool, I'll do that. No, the child doesn't know. The child thinks they're sick. And again, the parent is enjoying being in that role of having a sick child and having doctors concerned about them. But that it's child abuse is what it is. But it's in the DSM, so it's a disorder that's also child abuse. Okay, malingering, not a disorder, but it is a diagnosis in terms of it's a decision you make. So this is when somebody's faking for secondary gain. Like when I was a kid trying to get out of school, faking sick, that's malingering, right? So if you're presenting any kind of somatic symptoms because you're trying to get a workman's comp claim, or you're trying to get out of going to work or school, or you're gonna sue somebody because you fake like they hit you with their car, or you fell in the grocery store, and you're faking these symptoms. I have all this neck pain after falling in HEB. Okay, you're trying to get paid. Well, that's malingering, which again, it's not a disorder. It's not a psychiatric disorder. You're not mentally ill. You're just a liar, right? Cheating. And malingering can be with physical symptoms, but there can also be malingering of other psychiatric diagnoses, right? So somebody could be pretending to be depressed, pretending to have major depressive disorder, or pretending to have schizophrenia. If they do, well, they're malingering. And again, not a disorder, but it is a diagnostic decision. Okay, moving on to the dissociative disorders. Key feature of the disorders in this group is a disruption in the usually integrated functions of consciousness, memory, identity, or perception. So what does that mean, the usually integrated functions? Well, typically you know where you are, where you've been, who you are, and what's going on, right? And you can kind of put that all together because they're all related. Because part of knowing who you are involves knowing where you've been and what you see and what you hear. And in your brain, in your mind, you're putting all this together. With dissociative disorders, at least two, usually multiple of those processes aren't working in conjunction. So there's these gaps. Right? So when that happens, you get these dissociative symptoms. And generally three types. One, depersonalization, which is that feeling that, I'm not me. derealization, that the world isn't real, or amnesia, you can't remember things. Okay, so the disorders. One is depersonalization-derealization disorder, which used to be just called depersonalization disorder, I believe. So persistent and recurrent experiences of, you guessed it, depersonalization, which is, as we said, I'm not me, so experiences of unreality, detachment, and being an outside observer of one's own experience. So where you feel like you are almost like have an out-of-body experience where you're watching yourself, but this is me talking and these are my hands, but they're not me. If you ever seen, was it Being John Malkovich? If you haven't, good movie. That's kind of gives you a good idea of depersonalization, where you enter somebody else's mind and you're them, but you're not them. So but having that with yourself, where you don't feel like you really are yourself, like you're watching yourself on TV or in a dream. So recurrently having that experience and or derealization. So having both of these or just one of these. Derealization, again, being these experiences of unreality with respect to your surroundings. So the world's not real. So feeling like, yeah, I'm me, I'm first person perspective, I'm clearly me, but everything seems fake, like this, like I'm in a, not that I'm watching myself on TV, but I'm in a TV show. It feels like I'm in an episode of Star Trek and all these people are just saying their lines and they're not real people. I'm in the Matrix and it's a simulation, or I'm in a dream world, everything's kind of foggy. That would be an experience of derealization. So the world is, for a brief period of time, not real. So during these experiences of depersonalization and or derealization, reality testing remains intact. So that's important because it helps distinguish these experiences in a dissociative disorder from a psychotic episode, right? Because in psychosis, which we associate with schizophrenia, there is a loss of contact with reality. You have impaired reality testing. Impaired reality testing, the best way to think about it, one of these ways, if you've seen Beautiful Mind with Russell Crowe, toward the end when he's kind of portraying John Nash in recovery, and someone walks up to tell him, I think that he won the Nobel, and he stops and asks someone, hey, do you see this person? Yeah, I do. Okay, they're real. So he's testing reality, right? So not accepting that it's a hallucination if it's something abnormal, not saying, oh, okay, the aliens have landed. Oh, here are the aliens. But it's going, huh, aliens, that really doesn't make sense. I don't think aliens are here. That's when reality testing is intact. So if you have this thing where I don't feel like I'm myself, but I am myself, this is weird. So if you experience it as weird, as this is strange to have these feelings, well, then you have intact reality testing. If you don't, if you just kind of go with it, I'm not me. I am, I am the risen Christ. Okay, now we're talking about, delusional disorder or some sort of schizophrenia, psychosis. But if you think, yeah, I kind of feel like I'm some other person, but that's weird, then the reality testing is still intact. Okay, and like most other disorders, it causes clinically significant distress or impairment in multiple areas, and it's not caused by drugs or a medical condition, or better explained by another disorder. Interestingly, individuals that have this disorder, and to a general extent the other dissociative disorders, when they're not having these experiences all the time, right? They're recurrent, but it's not just always tripping. They have moments where they're lucid and present and okay, but they tend to have some attentional difficulties even when not having one of these episodes, right? So they look a little ADHD, a little scattered, a little Luna Lovegood for your Harry Potter fans, which may be part of what makes them susceptible to these other experiences. Okay, so like conversion disorder, transient symptoms are common, right? If you've ever had deja vu, well, that's a little bit of derealization. Like, wait, what did I just? Have I done this before? Right? That's a little taste. That's on the spectrum of this kind of dissociative experience of derealization. You can have those in moments of heightened stress is when they tend to be more common. People with PTSD, with panic disorder, and those kind of high stress moments, panic moments, response to big stressors. There can be some depersonalization, some derealization. But again, this is where people are having it not just when they're stressed or in response to a trigger. It's kind of this recurrent thing that's happening for them. So it's happened once, usually after trauma, but then keeps happening. Pretty rare. Lifetime prevalence rates are around 2%, so more rare than a lot of the somatic disorders we just talked about. In terms of what causes it, yeah, it's still a bit of a mystery. This is the dissociative disorders in general are a difficult group of disorders to study. They've always fascinated psychiatrists and psychologists, but they really don't have a whole lot figured out with this. It does seem pretty clear that trauma is common across the dissociative disorders, including depersonalization-derealization. There seems to be, for some individuals, again, not everybody who experiences a traumatic event develops a pattern of psychopathology afterwards. Some develop PTSD, some develop DID, some develop depersonalization-derealization disorder. Why this path rather than some other path? Again, there's probably some sort of genetic vulnerability. There may be some developmental things going on here in terms of the timing of the trauma. Not real clear. In terms of treatment, again, for psychotherapy, if somebody is dissociating in session, so having an episode of depersonalization, derealization while you're talking to them, which can happen, especially if they're prone to it, and then you're working on the trauma, right? When you work on the trauma, that can trigger a dissociative event. And typically what you do then is a grounding exercise, where you just quite simply, okay, I can see you looking off into space, and I get the feeling that you're not in the room right now. Can you hear my voice? And often they'll respond, I can hear your voice. Okay, right now, can you feel the chair under your arms? Okay. Can you hear the hum of the fan? Can you see the ugly fluorescent lights, right? You have them start grounding them back in the room, in the present, in the moment. Okay, you're here in this office with me right now. It's 3:45. It's kind of chilly. Can you feel that? And you kind of orient them to all the sensations that they can feel in the moment right now. And that can kind of bring them back cognitively in the room with you and out of that dissociative event. So that's just a technique to do while doing the other stuff. The other stuff being most of what you're doing in therapy, which is processing the trauma. So same type of stuff you're going to be doing with PTSD. Same type of work. And again, maybe prescribe medication for the associated anxiety. And I'll say it one more time. Drugs are pretty good at making you not feel anxious, but they're not a great long-term plan because of the potential for misuse and addiction. Okay, dissociative amnesia. Obviously, the inability to recall important autobiographical information, usually of a traumatic nature. This isn't like, I can't remember where I left my keys, or what was my great-great-aunt's middle name? Right now, this is more like, I don't know who I am. I don't know where I'm from. I don't recognize these people who say they're my family. So important autobiographical information, the kind of the big basic stuff. Pretty simple criteria. So that it's clinically significant distress or impairment, not caused by drugs. You're not high, not caused by a medical condition, a tumor, and not better explained by another disorder. And then you specify if a dissociative fugue is present. In dissociative fugue means flight, right? Where there's some travel away from home. So they end up in, they're from Texas and they're found in Mississippi, and they don't remember leaving Texas. They don't know who they were, who they are, but they've left. They've traveled. 12-month prevalence rate around 1.8%. And this is one of the ones that's interesting, especially with the dissociative fugue, because if you look at kind of the anecdotal evidence, some of the stories, particularly with the fugue, you sort of wonder, okay, how much of this is dissociation? How much of it is a conscious decision? Because the flight to somewhere else is often to Las Vegas, right? And it's after they've been discovered to have had an affair, right? Oh, I don't know, hey, what happened? I forgot everything and I just drove. Did you, or were you running away from some unpleasant consequences? But again, some people certainly do seem to struggle with this, but some people, there may be some malingering here as well. So the prevalence rates can be tricky to figure out. In terms of the causes, trauma, like most dissociative disorders, and some lack of memory for the traumatic event is normative, and it's again part of the criteria for PTSD. It's one of the possible symptoms. So if you just can't remember that traumatic event, you have amnesia for the trauma, well, you probably wouldn't add the diagnosis of dissociative amnesia if you meet criteria for PTSD. It's more that you don't remember the trauma and you've forgotten this other stuff about yourself, who you are, where you're from. In terms of treatment, well, usually the memories return on their own, right? So after the stress subsides, it comes back. So what do you do when it comes back? Well, you process the trauma, right? In particular, with this, narrative therapy seems to be effective, right? Crafting a story about the trauma that is where the trauma can fit into their view of the world and their view of themselves in a more adaptive way than what they're able to do before. Because the idea being here that it just couldn't fit. They couldn't come to grips with what this meant about them or about the person who did something to them, and so they had to get it out, had to forget it, cut it out of their mind. Make a lot of movie references today. Jim Carrey's Eternal Sunshine of the Spotless Mind, right? Too painful, I want it gone. But doing that at kind of an unconscious level. It's just overwhelming, got to get it out of here. So, well, how can we rewrite this story to where it isn't so horrific and threatening and painful to have this knowledge, right? So you got to give it some narrative context. Okay, dissociative identity disorder, and this is what a few DSMs ago was referred to as multiple personality disorder, the most misrepresented diagnosis in popular movies, right up there with schizophrenia, and often the two are mixed up in movies. So what is DID? Well, it's a disruption of identity characterized by two or more distinct personality states. So what's a distinct personality state? Well, that's when people subjectively feel that they are different personalities, and when they're in a different state, they act differently. They're behaviorally, cognitively, emotionally different. So their personality is different, right? And the term we use is alters, right? So you have your primary personality, and then this alter, maybe a second alter, maybe a third alter. The number of alters can range like 5 to, I think, 13. So they have these distinct personality states. They have recurrent gaps in memory, and the thinking here is generally, you come home and there's these clothes in your closet. Like, who bought these clothes? What the hell? Well, you bought them, but you bought them when your other personality, when another alter was in charge, and that there's amnesia between alters, where what one does, the other personalities aren't going to be aware of, and so can't remember, and so you end up having these big gaps of time where you don't know what happened. So, like most of the disorders, it causes clinically significant distress or impairment. And this is interesting. It's not because it's kind of generically in all the disorders, but not explicitly in the other ones. It is here. It's this experience of feeling as if you're someone else is not a normal part of a broadly accepted cultural or religious practice. Right? So if you're in this kind of cultural subgroup that believes in, okay, we're going to have this ritual, and then I'll be briefly possessed by this spirit or this entity, and I'll act this way. Okay, well, no, it's not DID. That's culturally normative. But again, a broadly accepted cultural religious practice. How broadly? It's up to your clinical acumen to make that determination. But it can't be somebody who made up their own religion. My religion says that I switch personalities. Okay, nobody else has a religion though? Well, then it's probably is DID. I don't have everybody doing that. But again, so there's this kind of explicit proviso in here that, but it's not culturally sanctioned. It's not normal and just weird to you. And again, not caused by drugs, another medical condition. So over there. In terms of the stats, 12-month prevalence, generally pretty rare, 1.5%, and for a long time it was thought to be exceedingly rare. Some newer estimates are much higher, as high as 6%. I tend to be skeptical of those. I've not met anybody with DID. I know one person that worked with someone with dissociative identity disorder, but just isn't something that I've seen presented a lot, and all the readings I've done up until the more recent ones, they've always said it's really rare, it's really rare. So I wonder about the increase now, because we've seen historically increases in diagnosis in response to movies, like when that All About Eve came out, when Sybil came out, there were spikes in diagnoses. So again, well, is that because people who have this saw those movies and goes, hey, that's me, I know what I have, and they go see somebody? Or is it because therapists are seeing it and thinking, oh, this client has some dissociative experiences, maybe they have this really rare disorder? Hard to know. There are some significant gender differences, with being much more common in women than men. Typically has onset in childhood, and when we get down to causes in a minute, there's a reason for that. So the causes typically, as a typo, severe, not sever, severe childhood trauma, and often incest. So really damaging, hard to deal with when you're a little kid. This person who's supposed to love me and take care of me is doing these things that I know are not okay. Right? And again, I can't be here right now. And the idea being that when you're young and cognitively you don't have you're still kind of this concrete thinker, and you have maybe some magical thinking, believing in Santa Claus, Tooth Fairy, right? These magical things. Maybe an imaginary friend. That when a trauma happens early on, before the age of 10, 11, 12, it's possible for the mind to go, okay, maybe there's this other part of me, and that thing happened to this person, and that person's going to go back in the back of my mind, and now I'll be here, right? And that's when the identity begins to split. So the bad thing that happened, the trauma, happened to this one part of the personality that shoved to the background, and this other personality that hasn't been victimized gets to take over. Sad. Notably, individuals diagnosed with DID tend to score much higher measures of suggestibility than other people. They are easily hypnotized, right? There seems to be an individual difference in how hypnotizable you are. These folks, very easy to hypnotize. And again, there could be something, it's hard to know which comes first, right? Are they suggestible because they've had this kind of fracturing of identity, or is this suggestibility kind of speak to this flexibility of identity that is already existing that allows for the differentiation of personalities in response to trauma? Not sure, but there's just kind of this correlation there. In terms of the treatment, like everything else with DID, you're processing the trauma, because there's 99.9% of the time there's a significant childhood trauma there for people that have DID. And like I said, 67% of the time it was incest. In addition to processing the trauma, you identify and neutralize dissociative triggers. So kind of like with PTSD, where there triggers internal, external events that can trigger a stress response that remind you of the traumatic event. Same thing with DID, but instead of getting angry or having panic, when they hit a trigger, they dissociate. So identifying those and then neutralizing those, which techniques for that often borrow a lot from what we know about treating phobias, right? Where you're going to expose them to the trigger enough, and they start to dissociate, ground them, expose them, ground them, expose them, ground them, and eventually they're able to tolerate the trigger becomes neutralized and is no longer a trigger. Can dissociative identity disorder be faked? This is kind of an ongoing question in the research literature in the scientific community. Spanos proposed this socio-cognitive model, which he's kind of in favor of. Yeah, it certainly can be faked. And his idea was that therapists are creating this disorder in suggestible patients, right? And it's based on not large-scale studies, usually more on kind of case studies. I think your book talks about that killer Bianchi, right, where he was faking DID, and they kind of showed that he was faking by suggesting different symptoms. Oh, well, you have 2 personalities. Well, most people that have DID have 3. And then a week later, I have 3. And then suggesting this, everything that was just that would get added to the picture. And there's a couple other anecdotes, which we won't get into, about Sybil suggesting that therapists can influence the presentation of dissociative identity disorder, or back then, multiple personality disorder. So therapists need to be really careful about this. If somebody has trauma, they dissociate. It's arguably inadvisable to say, well, do you have any other personalities? And the client goes, I've never thought about it, but yes, I do. Right? So if you go looking for it, you're more likely to find it being the thing. Along those lines, other researchers, outside of the clinical world, Elizabeth Loftus, has shown that false memories can be induced. So this idea that, but therapists can't make people feel or think certain things. Yeah, they can. Anybody can, especially in children and in suggestible individuals. You can create false memories in people via kind of sophisticated suggestion, and false memories are indistinguishable from real memories. Right after the memory's there, you look at EEG, PET scans, whatever, acts the same way, because again, memory is reconstructive. We don't really remember anything. Remember bits and pieces. We put it back together. If you can plant a seed that's not true, you're going to build up other true stuff around it, and then you can't tell the difference between the real stuff and the fake stuff. So yeah, there can be, people are capable of being manipulated. And again, these aren't typically therapists that are looking to, hey, I really want my patients to have DID. They may be thinking, oh, I think they may have it. I'm going to ask these questions. But if they do it in a leading way, it may lead to them to report more symptoms than they would otherwise. And then obviously criminals may malinger. They can try to fake it. And there's lots of studies about where you pay college students to try to fake it and see if can you tell the difference between the people that are trying to fake it, the people that really have it, and it depends on what measures you use, whether or not you can. On the flip side, to some degree, well, because if it's fake, then there really wouldn't be these differences among the alters. And so one kind of thing suggesting, well, maybe it can be faked, is there aren't consistent differences in implicit memory across altered states, right? So there's that, oh, when I'm Jim, I must have done it because now that I'm Sheila, I can't remember what Jim did, right? Because it's a different state. I have this inter-identity amnesia. Well, cognitive scientists, expose people to word lists, and then they can test your implicit memory for those words later, where they're not saying, do you remember these words? But they're giving you tests that can tell if you have memory of it, right? Where, okay, if you've seen these words before, you're more likely, I show you the words red, sweet, fruit, shortcake, whatever, and then I say, oh, pick a fruit, and you say strawberry. Okay, because you said strawberry, that's evidence that you remember these other words, because they're connected in this kind of neurological network. And there's all kinds of tests that do that. And there seems to be people's implicit memory is intact across alters. So if you show somebody words while they're in one state and then test them in another, and you don't do an explicit memory, like, do you remember this? If you say, do you remember this? They'll typically say no. If you do an implicit memory test, then they typically perform about as well as somebody else who doesn't have alters. But there are these interesting differences in optical functioning, things that arguably can't be faked. Like somebody that has a strabismus whenever they're in one personality state, and they don't have it when they're in another. And there's all kinds of different things where, and again, people can have differences in eye functioning across time, at one testing to the next. But the amount of difference you have for these people when they're in one personality state versus the other is significantly more than what you have in people that don't have DID, suggesting, yeah, there is something different going on. And there also seem to be some differences in brain function, looking at fMRI and PET scans, where the brain seems to be acting differently in these kind of okay, this is the character pattern. This is your brain at rest when this alter is in charge. This is your brain at rest when this alter is at charge, which is interesting. But from a therapist's point of view, the question becomes, well, does it matter if DID is, do you really have these different personalities? And from a therapist's point of view, it doesn't really matter, because these people have suffered significant trauma and they're experiencing dissociative symptoms. Whether or not those dissociative symptoms, align to our understanding of personality and different personalities, it doesn't really matter. We're going to still treat them largely the same way. We're going to be focused on dealing with the traumatic event, processing that event in a way that they can live their life without the need for these symptoms, because they do seem to be an adaptation, right? They don't want to dissociate, but they're dissociated to protect themselves, to protect their mind. Okay, take-home message. For somatoform disorders, it's all about stress being manifested as physical symptoms, right, and other psychological symptoms. It tends to be associated with hypervigilance to bodily sensations, right? So they're really very aware of their bodies and what's going on, and largely misinterpreting that. When people say, well, it's all in your head, for somatoform disorders, you're not really sick, it's all in your head. I would say, well, yeah, everything's all in your head. If you have the measles, to some degree, that's in your head. Sure, there's some systemic things happening in your body, but it's being processed via nerves that are going back to your brain, it's sending messages back down, and it's being regulated by that stuff, right? If you tell somebody some really horrible news and cause a lot of stress, they may develop hives, right? This allergic reaction, right? Excessive histamine going to their skin. Well, that's all in your skin. No, but it came from your brain. So everything, to agree, is in your head. So even people with somatoform disorders, when they say it's all in your head, oftentimes that phrase is used to downplay, oh, it's not that big a deal, it's just in your head. Well, it's still an issue, it's still a problem. And yeah, that's the problem, that it's in my head. And so I'm having difficulty with the stress, and it's coming out in these somatic symptoms, if I have somatic symptom disorder, or it's coming out where I have excessive concern about being sick. So it's all in your head as a dismissive thing. That's ridiculous. Everything's in your head. The dissociative disorders. Again, dissociation, the amnesia, derealization, depersonalization, the alters seem to be a trauma response, right? And where dissociation was a coping mechanism, right? So dissociation is problematic, but it's not typically the problem, right? That's the coping mechanism. Often comes, think of it like, to some degree, for some people, certain substance use disorders, addictions, where the addiction is problematic, but if they started using the substance because of something else, okay, well, then that something else is the problem. And with dissociative disorders, that something else is almost always trauma. And dissociation is just a coping mechanism. So if you can work with the trauma, if you can teach other coping mechanisms, then those symptoms may go away. And again, the symptoms go away, they're not fine yet, they still have to deal with the trauma. Because again, they stop dissociating, they may find a different way to cope with the trauma. So you still have to deal with the root of the problem. Okay, that's all for now. Take care.